So, one of my hands, I'm gonna be using the hypothenor eminence, and on the other hand, I'm gonna be using the thenar eminence, okay? So, I wanna produce a side bending motion, okay? I wanna perform a manipulation to improve side bending. So let's see what we got. 1, 2, 3, 4, 5, 6, 7. That's C7, T1, T2, T3, T4, T5. All right, I'm gonna say T5. This technique, according to Olsen, is good from T3 to T4 to T3 to T11, T12. So this technique is pretty much good for the entire thoracic spine mostly. All right, to produce side bending. So where am I at? T4? So I'm at T4. So at T4, my hypothenor eminence is gonna be on the transverse process on the left side. All right. Now, my thenar eminence is gonna be on the transverse process of T4 on the right side. Now, the hand that one of my hand is gonna produce, both are gonna do a PA. So I'm gonna rotate my thenar eminence and hypothenor eminences towards each other, like so. So I'm rotating them towards each other. Then as I impart a PA, so come and get over me from a superior aspect. So as I impart a PA, I am creating a side bend to the left on T4. So do you see this? So again, I'm on T4 and I'm mobilizing T4 on T5. So again, my left ulnar, my left hypothenor eminence is on the left transverse process of T4, and my right thenar eminence is on the right transverse process of T4. I rotate my hands towards each other, so I'm rotating them each one towards each other. Then I apply my PA, and as I apply my PA on T4, what that's creating is a left side bending. So T4 is moving like this. You see that? So we get a left side bend of T4 on T5. You got that? That's what's happening. So I come here and apply my, rotate each hand and apply my PA, and now I'm getting a left side bending of T4 on T5. All right. So it's always good to start with your model so that you can visually see it. So everybody, when you practice these techniques on somebody, come in and practice them on the model, and that's gonna help you on your lab practical, because you're gonna be able to recall what you also did on the model, okay? So you can do it from either side, okay? So say if I wanna improve right side bending, or work on right side bending, I can do that, right? So now, if I want to work on right side bending, now on the right side, my hypothenor eminence is going to be on the right transverse process of T4, and my thenar eminence is going to be on the left transverse process of T4. I can rotate my hands towards each other and apply the PA, and now I get a right side bending of T4 on T5. So I got this motion now. Right side bending of T4 on T5 when I do that. Okay. So who wants to serve as the patient? All right, come on. I'm bouncing a little bit of flexion. Go ahead. So that opens things up just a tad bit more. So I'm at inferior angle. So we know inferior angle is what? Inferior angle.
T7.
Okay. So I'm gonna come right here. I rotate each hand on each other. All right, T7 on T8, you say? All right, now, I mobilized her, right? Yes, I didn't do a thrust. All the time you don't have to do a thrust. She probably wants me to do a thrust, right?
Yeah.
That's why she volunteered. All right.
Is she relaxed after potty?
I'm making sure she's relaxed. All right, take a deep breath in for me. All right, and blow out like blowing out a straw. Okay. All right, I'm gonna kind of get at a diagonal. Get in on that. Get it up. All right. Take a deep breath in. And I'm not gonna lose it. Blow out like blowing out of a straw. I'm gonna go down with it. There you go. So that was side bending to the left. All right, because this hand's, I got a PA going, but this is my hand moving caudally, so it's moving in transverse process anteriorly, but also caudally. This was my right hand is moving T7 transverse process anteriorly, but also cephalic. So now you get a side bending to the left. Okay. She got several releases. Like before I even got there, she got some audible releases. So that was good. All right. How you feel?
That was great.
All right. You go ahead and sit up now.
I'll set up a rotation.
Wear your uniform. The rib is very simple. This mobilizes the mostly 3rd through 12th ribs according to Olsen. But you get in on, you can feel the rib cage, right? So you just get a good hand placement over the rib cage. This one is simple, very simple. And go ahead and exhale. He has one hand applied. Inhale and exhale. And so I'm applying a force as she exhales. And so as she exhales, then that's mobilizing her ribs with a PA. And I just keep my force there. Go ahead, exhale. So as she exhales and my force is coming down, that's mobilizing her ribs with a PA. Very simple technique, but a good beneficial technique. All right. And then I can also mobilize the opposite side. All right. Exhale. There we go. Good. And as she inhales, I can follow down with that. It's almost similar to mobilizing the first rib. So I keep my pressure applied there. And this helps to improve rib mobility. Okay. The first technique that we did is contraindicated if someone has what? Osteoporosis. So in these thrust manipulation techniques, if someone's had osteoporosis, you want to stay away from those because you can easily cause a fracture. Okay. Osteopenia, I would be cautious as well with osteopenia. All right. So those are 2 techniques that we want to add.
I wanted to work on T6, find my spinous process, find the corresponding appropriate transverse processes. So if I got here, I like to get here on with my hypothenar on like my pisiform. I feel like I can palpate with my pisiform here on that transverse process. Then I'll take my other pisiform, put it right in through there, and this is how I like to do it. Okay. So then I sink through, find there, take up the tissue slack, and then I can hold just a static stretch. I can do my oscillations, and or I can do a thrust. Okay, does that help? Any questions? questions?
That may work better for you, Kendall. Cause I was going around looking at some of you all, cause if you have like decreased strength. So of course I had the strength to do one of my hands, but I can see that being beneficial for someone who was weaker to use both hypothermia.
I feel like I can get my forearm, get the core spine of my forearm a little bit better here. Right here.
And so in the frontal plane, if I side bend to the right, what's happening with rotation of the lumbar spine? So this is non-functional. So in the cardinal plane, movement in the cardinal plane is non-functional movement. So make sure you pay attention to this, because now I'm going on a National Physical Therapy exam content. This is a recap. I've already taught this. This has already been taught. This is a recap. This is non-functional versus functional movement in the spine. So we went over in each segment. So for thoracolumbar is the same with non-functional and functional movement. So when you move in your cardinal planes is referred to as non-functional movement. Why is that? Because we typically come out of those planes and we typically move in diagonals for functional movement. So if I'm side bending to the right, thoracolumbar, what is happening? What other motion is being coupled with that in this frontal plane? Rotation to the opposite side, rotation to the left side. Okay, so but now say that I am I'm side bending to the right. All right, I'm side bending to the right, but also I'm also rotating and bending forward to reach down to grab something, right? I'm side bending to the right, but which way is rotation occurring? Rotation is also occurring to the right, because now I'm doing something functional. So now that I'm doing something functional that's taking me out of the cardinal planes, so I come right here, lean over like this, I'm side bend to the right, and I'm also doing what? Because I'm trying to tie my shoes, tie my shoes. So when it's functional movement with the thoracolumbar spine, side bending and rotation occur to the same side with functional movement. With non-functional movement, side bending and rotation occur in opposite directions. Make sure that you know that. That's for the thoracic and lumbar spine. Okay? Go back and review that presentation. You have to know that. That's National Physical Therapy exam content. So we have to know this for foundations for initial examination, evaluation, differential diagnosis, and prognosis. So that's your foundational concepts. Go ahead, Dr. McClure.
Just remember two terminology, right? So Dr. Carter said functional, right? So functional versus non-functional. You could also see it written as physiological, okay? Some textbooks write functional motion or physiological motion, or you might even see non-neutral motion, meaning it's in a flexed or an extended position, okay? So to the contrary, you could see non-functional motion, okay, or non-physiological motion if it's in a straight plane, okay, or neutral. You can see it as a neutral dysfunction if it's in neutral, okay? So just remember those terms are interchangeable in regards to that. Bryatt's laws, right? Bryatt's laws.
Okay, so now the next technique that we're going to learn today is the mid-lumbar rotation and sideline. We're going to create a ligamentous tension locking and a facet distraction with this technique, okay? With this technique, you don't want to use this technique on someone who has symptomatic bulging, herniated, or proposed annulus nucleus in the disc. So be cautious to screen the lumbar spine before doing this technique. All right. It could likely be beneficial for someone with spinal stenosis. It just depends on the severity and what the person presents with. So how do I screen the lumbar spine? How do I screen it and do a quick screening? Because people come to us with direct access. They haven't had any imaging done, and they haven't had any x-rays or anything. So typically I screen the lumbar spine with repeated movements in the cardinal planes. I would have the person perform lumbar, thoracolumbar flexion, having to hold it for about 3 seconds, come back up nice and slow. What am I looking for in order to proceed with a technique like this? So I'm looking to see if they have any ridiculous symptoms going down the leg. If they have ridiculous symptoms, they could let me know they could potentially have a bulging disc, especially with flexion. So with flexion, they could have a posterior lateral bulging disc. I'm gonna go over that when I talk about the McKenzie method. Have I talked about the McKenzie method yet? I have. Okay. So this is a recap then. I will have, say again? Okay, you read about it. So I'll have them flex again. All right, going as far as they can. Have them to come back up. Make sure they don't have any symptoms from forward bending. So now, if they don't have symptoms from forward bending, nothing at all, no pain, no ridiculous symptoms, because they could have localized pain that could come from myofascial tightness and just tightness in the lumbar spine muscle. Most likely they will report a pulling sensation. That's what they will report. And so going back, if that is clear, if I clear flexion and no ridiculous symptoms, that most likely tell me they may not have a bulging disc, a symptomatic bulging disc. So what I mean by that, most of us could be walking around with bulging discs, but the bulging disc is not symptomatic. So that lets me know that they don't have a posterior lateral bulging disc. All right. Then I test, because I got to go back and explain some of this, because y'all probably like, what is Dr. Carter talking about posterior lateral bulging disc? So when I assess backwards bending, I have them lean backwards. I'm making sure that they don't have any ridiculous symptoms. All right. Looking, squeeze it backwards. Make sure they don't have any ridiculous symptoms. Now, if they have ridiculous symptoms, it could be either spinal stenosis and encroaching and squeezing down on neural structures, nerves, or it still could be a symptomatic bulging disc, but it'll be a posterior medial bulging disc if they have symptoms with backwards bending. Okay. So it can still be a bulging or herniated disc. We don't know if they haven't had imaging, but we just going off of the signs and movement, okay? So now, if they have ridiculous symptoms, I will still avoid this and recommend imaging, and I'll take a more conservative approach with treatment, okay? So I may base my treatment based off of movement patterns. So if they have increased pain with backward bending, increased ridiculous symptoms, and they don't have it with forward bending, then I'm gonna go with some William flexion exercises. I may do some soft tissue work with them in a forward bent position, but that's something we haven't shown you all yet. Then if they have pain with leaning forward and it causes ridiculous symptoms, then I'm gonna go with extension principle exercises. All right, and I may do some soft tissue work as well with them being lying prone. So that's how you screen the lumbar spine. You can also incorporate side bending, have the side bend twice to each side, see if that reproduces any symptom, and having to rotate to each side twice and come back. So you screen the lumbar spine with all of your cardinal movements, and you having to do repeated movements. It's gonna give you information. What you're looking for is information. Okay. All right. Anybody here got any low back problems? Low back stiffness, low back pain? What do you think it is?
I don't know.
Tightness.
Tightness. Okay, so she lied on that side. Okay, so the first thing with this technique to help you remember the side that you're mobilizing to, let's do this. I'm gonna take this. So she's lying on her left side, so her right side is facing the ceiling. So the side that she's lying on, that's the side that the side bending is gonna occur to. The side that is facing the ceiling, that's the side that the rotation is gonna occur to. Everybody got that?
Can you just get like one more time for clarification?
Okay, the side that she's lying on, she's gonna be side bent to that side. The side that the ceiling is facing, the side that's facing the ceiling, that's the side that rotation is gonna occur to. All right? So her right side is up, so this is gonna be mid-lumbar, rotation, right, and side bending, left. All right, ligamentous tension locking, facet distraction. All right. Oh, go ahead. Let me put this up under your waist. This is gonna help me out a little bit more. Lift up. Come on, lift up a little bit more. There we go. That's it. Now, scoot towards me. Keep coming. All right, there we go. All right, now this is what I want to do. I'm gonna take you. I'm gonna raise you up some. All right.
My head don't know what to do.
Your head, I know what to do. I'm just gonna rotate her like that.
I keep my feet together like
Yeah,
this.
keep your feet together like that. And just relax it on right here for right now. Okay, so now I'm gonna take her right leg, right? Left leg. And what I'm gonna do, I'm gonna come back here and take my, so occasionally you may have to come around the other way and record because she chose this side to lie on. So now I'm gonna create my ligamentous lock because I'm flexing her, right? So remember, we create our ligamentous lock when we flex to the level. So I'm gonna flex her to L4 to where I feel a gap in between L4 and L5. So I'm using like a little dimple right here when I can sense that, right there. I got her right there. You feel that, Z? So I'm gonna take this leg and kind of place this foot behind her knee. She's in a flex position. So I created the ligamentous lock. We can do this. I'm gonna let Dr. McClure show you how to do it from the top down. So I'm doing it from the bottom, from the legs. You can do it from the top down as well. I'll let Dr. McClure show you all that way. And so I kind of get in, I'm making sure, so I'm maintaining this ligamentous lock to this segment with my thigh, with my left thigh. So she's locked here, she's not going anywhere. You see my left thigh maintaining her right here, and then I kind of bring her into some adduction, hip adduction. I got her where I want her now. She is where I want her. This is the setup, all right? Now, I'm gonna rotate her towards me a little bit more. That's gonna help me, all right? From her arm. Now you're gonna take this arm and just get in on my arm and just kind of hug me. Just kind of hug me. Okay. All right. So now, again, she's side bending how?
To the left.
And how she's gonna rotate?
To the right.
All right. Now what I'm gonna do, I'm comfortable right here. All right. So I'm gonna back up off of this because I need to show you what I'm gonna do. I'm gonna elongate her. I'm gonna elongate her like this. This is what I'm going to do. I'm gonna elongate her as I drop my weight, okay? But my focus is more so on the elongation, all right? A lot of people mess up right here and they just go and try to crank. A lot of people just try to crank at this point. So watch this. All right. No, you see how I'm elongating? I'm elongating her. Now, as I elongate her, I got her elongated. Now, what am I gonna do now? There we go. Once I got her elongated, I use my thigh and just drop my weight like so, and then she gets the rotation to the right, more side bending to the left with the thrust technique. Okay, all right. Now, since my patient came in limited with lumbar, side bending left, and rotation right, then this can be a technique that can be utilized. Okay. Now, can I use this as an assessment? Yes, because always manipulation, mobilization is ultimately assessment. So I could not have thrust her, but I could just have gotten a feel. Because we can always assess feel and end feel with what we do, right? And then come back and treat and then reassess. All right. How you feel, Z?
Feel good.
All right, good.
So if I was gonna do this technique here, so when you say top down, are you saying
So
initiating rotation first? So Dr. Carson, you can do the technique where you're getting the actual manipulation by a distraction, boom, okay? Or you can set them up and you can do it and you can stabilize a little bit more and create more of the manipulation from the top, okay? So through the shoulder, or you can create the manipulation, get it all set up and create it more by creating it through the pelvis from the bottom up, okay? Does that make sense? All right, Tia, can you scoot toward me a little bit? So either way though, I'm gonna create a facet lock, okay? Or I'm sorry, ligamentous tension lock first. So, can I get one more pillow? No, I love pillows. Okay, I'm just gonna hold this, keep this handy. What I'm gonna do, again, is I'm gonna to locate the level. So if I was gonna create this more from top down, I'm probably gonna do that on a segment that's higher in the lumbar spine, okay? So if I come across here, remember your landmarks. So if I come on iliac crest and come straight across, this should put me right about the L4, L5 interspace, okay? So I'll walk my way up here, L3, L4, L2, L3. Let's say I want to do L1, L2, okay? I'm gonna get top leg, I'm gonna come across like this, and Tia, I'm gonna use your leg to create flexion in your lumbar spine. So I'm gonna flex you up to this level, right? And if this is actually a technique that's in your section on your lumbar lab sheet as well, the lumbar forward bending, passive intervertebral motion, this is essentially it. You're assessing motion, right? So I'm going to assess motion each level. I've determined that L1, L2 is the level I want to treat. So I'm coming up here, I'm forward bending her until I feel that inner space open up between L1, L2, right there. Okay, her bottom leg is flexed about 30 degrees of hip flexion. Okay, once I get her flexed with the top leg to L1, L2, I'm going to put her leg down like this, and I'm going to lock her. Okay, now I may get in like this, and I'm going to actually lean into her a little bit. Okay, and I'm going to stabilize her here, so she is locked down right here. I'm going to switch my finger hold, so I'm still L1, L2 inner space. I'm going to get her up like so. I'm going to take her bottom arm. Tia, I want you to grab the back of my elbow with this arm. I'm going to use that to rotate her down with a facet to create a facet lock until I feel motion again. L1, L2. You okay?
Yeah.
Okay, sure.
My hat just came home.
Okay. All right. You're good. All right. Now I'm going to take her arm and I'm going to tuck it here, and I'm going to come through up here. Okay? So now I've got my finger on the bottom side of the spinous process of the inferior level, so L2. I've got my top finger here on the top side, or the side closest to me, of the spinous process of the superior level, so L1. Now I'm going to get here, so I've got her locked down caudally, right? I'm going to come in here. I've taken up the slack with the rotation via her arm to rotate her down to this level, okay? And then I can choose what technique I feel like I need to do. I still feel like Tia there's a lot of slack here between her shoulder and my shoulder. So I feel like I'm not fully, I still feel like there's some give here. So I'm gonna sink through. You okay, Tia?
Yeah.
Am I putting too much pressure here? Okay, so I'm through her shoulder and her upper ribs. So I could have her breathe and just oscillate. Okay, I could do a progressive stretch here. Okay, or I could do a thrust manipulation. So if I were to do a thrust, I could follow her breathing, have her just take a normal breath in for me. And then as she goes out, I'm gonna take all the slack, and create the thrust top down. Okay? You okay? Got her there, and I just have her stabilize. I might even take my hand off of the spinous process, get it on the hip, and just, okay?
Some of them you just get a release with the setup.
Yeah.
Some of you are just gonna get a release with just the setup.